Thank you very much, everybody. Welcome to New York City. Welcome to Mount Sinai. I'll start by saying thank you very, very much to Dr. Oliver, Haiti, and Tina for inviting me again for this talk. Last time I did it was about 4 years ago, so we've had some new data that's come out, and they've given me the task to talk to you about guideline-directed antiplatelet therapy, specifically in acute coronary syndromes. I will focus largely on the non-ST segment elevation flavor, and specifically the antiplatelet therapy and how the guidelines help us with that. One caveat I will say, this is a complex topic, a lot of guidelines out there, and as Beth said, we focus more on the ACC AHA guidelines here, but when it's complex, my idea of tackling that is to make it simple. And that's my job for you today. And in keeping it simple, I'll keep it short, so I will not be responsible for keeping you from lunch. The most important thing. Oops. Okay, unfortunately, I do not have any disclosures to tell you about with my financial. And the references we use really on a daily basis are the American Heart Association and ACC. The last iteration of the ACC-AHA was in 2016, and this is a new one that came out. It was a focused update on duration of dual antiplatelet therapy, specifically in patients with ACS. And then that is on the backdrop of the large 2014 baseline guidelines that help in the management of patients with ACS. And then there was recently a really nice update on acute coronary syndromes in the Journal of American Medical Association as a review, and sometimes it's helpful to go to the review for a lot of the guideline-driven data. I scroll down, right? Okay, so when we talk about guidelines, everybody sees this box. Does anybody really know what this box means? So that's what I want to tell you about. So on the top, we talk about class. We talk about a class recommendation. What is the class recommendation? Simply, it tells you what is the benefit versus the risk. Class 1 is the benefit significantly outweighs the risk of that management. Class 3, it's the reverse. The risk is much more than the benefit. But what is the column on the left? You see this quality of data type stuff, level A, level B. Well, that's the evidence that supports the class recommendation. So when you have a class 1 recommendation with a level of evidence A, those are multi-centered, randomized trials supporting that class 1 recommendation. You can't get better than class 1A, okay? So that's really important to know that. On the opposite end of the spectrum, the lower right-hand corner, you have class 3C. So it's incredibly harmful, and there's no data to support using it. So don't use it. So on the bottom, in the clinical realm, we always say, do it for class 1, can be useful for 2A, consider it for 2B, and don't do it for class 3, okay? So have that in the background when we go through our guidelines here. So by way of review, I put this schematic up of the platelets as a way to review the different receptors that we have on platelets and the ones that we've exploited for patients having an acute coronary syndrome. And I'll focus your attention more over here. And this is the P2Y12 receptor. This is the receptor that most of our antiplatelets that you're familiar with act upon. And they are otherwise known as ADP receptor antagonists, adenosine diphosphate. And you've heard of these. So clopidogrel, prasugrel, Ticagrelor, and Cangrelor. Those are the ones we're going to focus on today. The 2B3A inhibitors have really fallen out of favor. We don't really use them. There's some support with the guidelines, but they're 2B recommendations at best. And then the thrombin inhibitors, we're not there yet for those. So this is just a schematic to show you where we are physiologically when we talk about these antiplatelet medications. And here they are. I told you them before. We divide the antiplatelet medications up into two classes. One is the thienopyridine, and the other one is the non-thienopyridine. Ticagrelor is really considered a non-thienopyridine, so you have 2 and 2. And that is really the chemical composition that makes up the compound itself. But the one important aspect of all these, there's some reversibility, but the most important one is, one of them is IV, intravenous, and this is the new kid on the block, which we'll talk about later. Okay, so whenever I give this talk, I can go through guidelines, but guidelines are incredibly boring. Everybody will fall asleep, so I want to do this. We don't have the way for people to vote in the audience, but that's okay. Is to have this question driven, so you can remember. That's the only way you're going to remember. So let's go through a case. So this is a 75-year-old female with chest pain. She has a prior history of a transient ischemic attack, TIA, 8 months ago. She has known coronary disease with a prior 3-vessel bypass in 2012. She has an ICD, diabetic, and hypertension. She now comes in with chest pain to the emergency room, shortness of breath and diaphoresis for 6 hours with an initial high-sensitive troponin of 3.4. Her vital signs are stable, and the exam is pretty much unremarkable. We call the ER team, and they do an EKG within 5 minutes, and this is what we found. So, cutting to the chase, you see some ischemic changes here. You see ST segment depressions in both the lateral leads and the inferior leads here. So a little bit of a concerning story, very concerning story, with a very concerning EKG presentation. So I'll pose this first question to everyone. Which of the following is the most appropriate antiplatelet therapy to be given to this patient in the ED? Would we give enteric-coated aspirin 325, enteric-coated aspirin 81, non-enteric-coated aspirin 325 chewed, or no aspirin given the patient had a recent TIA? Very good. C. So a lot of people get stuck on this, including our fellows, and I'll talk about what enteric versus non-enteric-coated, but this is why we choose aspirin. This is a class 1 level of evidence A. You can't get better than that. So as quickly as possible for those patients that are deemed definite or likely non-ST segment elevation MI and treated with an initial invasive or ischemic guided therapy, a non-enteric coated aspirin in a chewable form in a dose of 162 to 325 should be given to all patients. And I think we do a pretty good job at this at our institution. I know we do. And then to go on, they also support a maintenance dose. Now the maintenance dose is going to be a lower dose. This is the 81 milligrams, and this should be continued indefinitely, lifelong. Okay, so there's our evidence, class 1 level of evidence A for aspirin. So why the enteric-coated versus non-enteric-coated? So this was a very unique study done a few years back. That these were healthy volunteers, mind you, but we gave them, or Dr. Grosser and his group gave them enteric-coated versus non-enteric-coated. And the y-axis is looking at platelet aggregation. So the lower the bar, the better, meaning the platelets are not clumping. So you can see here, 8 hours after a plain aspirin, 325, none of the platelets are clumping. If you give enteric-coated aspirin 8 hours after 325, you're starting to see clumping in patients, and even 4 hours after. So up to 4 hours, you're still not getting an antiplatelet effect with enteric-coated aspirin. That's why we don't use this in acute coronary syndromes. So very, very important to understand that. Okay, moving on. So in addition to treating this patient with aspirin 325, which of the following additional antiplatelet therapies is most important? I emphasized most here because there are maybe a few correct answers here. So ticlodipine, I'm not sure if there are people in this room that still remember that drug. Maybe there are. Prasugrel, 60 milligrams, Ticagrelor 180, or clopidogrel 300. C. Wow, you guys have read the guidelines. Excellent. C. So why are we going to use C? Why not the other one, the other new kid on the block? So the guidelines tell us that this is a class 1 level of evidence B, still really good evidence, of loading a P2Y12 receptor inhibitor before undergoing an urgent or emergent cath. So you can choose any one of these. You can choose clopidogrel. Now that answer was clopidogrel 300. That's not what you want to do. You want to use 600. You can use Ticagrelor 180, but you can also use Prasugrel 60 milligrams. And some of you may have been swayed by Prasugrel here, but there's something in this patient's history that you have to be careful of, and we'll talk about that. So in this, the guidelines tell us aspirin and some sort of P2Y12 receptor antagonist, whether it be clopidogrel, Ticagrelor, or Prasugrel. Class 1, level of evidence B. Very important, and do it up front, upstream. So why Ticagrelor? So this one, it's downgraded a little bit. They gave it a class 2A. There are definitely randomized trials that support it. And they say, they cushion this a bit. They say it's reasonable to choose Ticagrelor over clopidogrel. So if you wanted to give clopidogrel, it's okay. But the evidence is really more supporting towards Ticagrelor for P2Y12 inhibition in the non-ST segment elevation MI. So it's okay to choose Ticagrelor in these patients. And this is the trial, this is why we chose this. This is Plato. This is now a 10-year-old study that looked at patients with acute coronary syndrome, 20,000 patient study, large study, compared clopidogrel versus Ticagrelor. And at 1 year out, those patients that received Ticagrelor had a 16% decreased risk of developing the primary endpoint of death, MI, or stroke. Death. There has never been an antiplatelet agent out there that has reduced death. This is why we love this medication. It decreases cardiovascular death. So this is why the evidence is so good for it as well. What about prasugrel? So the guidelines say it's okay. It gives it a 2A level of evidence B, and they say it's reasonable to choose prasugrel. You should load it 60 milligrams if they're going to the cath lab. But be very careful in using it in patients with a prior stroke or a TIA. And if you remember that patient that we presented, she had a TIA 8 months ago. So that's not the drug for this patient. You got to be very careful with this medication. And the reason why was shown in the TIMI-38 trial. Again, about a 12-year-old study now that compared prasugrel versus clopidogrel. Again, huge multi-center trial. Showed a significant 19% relative risk reduction in those patients that got prasugrel to the primary endpoint. This one did not show improvement in cardiovascular death, but it did show improvement in recurrent MI and stroke. The problem with Triton and prasugrel, as you know, there's no free lunch, and that's this bottom curve. So there was a statistically significant increase in fatal bleeds with this medication. And those bleedings occur with certain populations of patients, elderly, low body weight. So you have to be careful with this medication as well. But the guidelines do support it. So they support it, but they also give a class 3 level of evidence B. So this is the harm. So do not give prasugrel to patients with a prior stroke or TIA, just as our patients had. That's why if you chose this medication, you'd be in a class 3. You really don't have a leg to stand on if it goes to a medical legal issue. So stay away from that in those patients. In fact, the maker of prasugrel went ahead and issued an FDA-supported black box warning, and there's 3 patients you should not use this medication with. 1, anyone with a TI or stroke, anyone in the age greater than 75 years older. These are the people that had fatal intracranial bleeds. And then anybody with a body weight less than 60 kilograms. Those patients also have significant bleeding. Oops. How'd that happen? Okay. So this patient got taken urgently to the cath lab. This is her case. You see this is a selective coronary angiogram of the right coronary artery. And you see in the mid-segment there about a 50 to 60% lesion. Nothing too bad. But then in the distal segment, it's nearly subtotaled. It's not totaled. That's why this patient didn't present with a STEMI. This is more subtotal. There's TIMI2, TIMI3 flow in that distal vessel, which means blood is still oxygenating the muscle. That's why your EKG presented as she did. But this lesion in the distal RCA looks probably like the culprit, okay? So even though my talk is on antiplatelet therapy, it would be amiss if I didn't throw some type of anticoagulation question in there because we face this all the time. So the decision was to go to the cath lab. The patient was treated with aspirin 325, Ticagrelor 180, and transferred to the cath lab. Which anticoagulation regimen is recommended for PCI? Fondaparinux, bival, bivalirudin, or unfractionated heparin, or enoxaparin? Excellent, excellent. You didn't get swayed by fondaparinux. So fondaparinux is something that we haven't really seen in prime time. It is an enoxaparin type. It's a low molecular weight type heparin. It's used more in patients that are treated medically, not for patients going to the cath lab. This is not a medication you want to use or have even in your algorithm for anybody that goes to the cath lab. It comes as a brand name called Atrixa, I believe. I've never prescribed it, so I don't use it. And the reason why, in the cath lab, this medication forms clots. Clots form on the coronary wires and in the guides. So very quickly, this came off any guideline directed for patients going to the cath lab. Not going to the cath lab, it's okay to use, but not in the cath lab. So correct, for those that chose bivalirudin unfractionated heparin, this is the correct choice. The guidelines, again, give really robust data to use this. Bivalirudin, a class 1, level of evidence C, as an anticoagulant with or without. That's important because in the ER, we impress it upon the ER to give a bolus of unfractionated heparin right when they give the aspirin. Even when doing that, you can still use bivalirudin. The guidelines support it. If you're undergoing PCI, unfractionated heparin is just as good now. Fondaparinux should not be used. This is class 3. Pay attention. Don't use it if you're going to the cath lab. So this patient, I told you, went to the cath lab. She underwent a drug-eluting stent to that mid and the distal lesion, actually with a very nice result, establishment of coronary flow. And now we need to decide, after a drug-eluting stent placement in the mid-RCA, which of the following would be the most appropriate. Aspirin 325 daily plus Ticagrelor 90 BID for a year. Aspirin 81 milligrams daily plus Ticagrelor 90 for a year. Aspirin 81 indefinitely plus Ticagrelor 90 BID for a year, or aspirin 81 daily indefinitely and Ticagrelor 90 BID for 6 months. Wow, you guys are getting 100. I got to make this more difficult. Very good. No, I'm really pleased. Everybody seems to be online and getting with the guidelines, which is very important. Here are the guidelines to support the duration. Now, this is a moving target. Moving target in patients with stable ischemic disease. Stable, not ACS. And I say stable because we have separate guidelines that support a shorter duration of dual antiplatelet therapy with stable CAD. But in the ACS patients treated with dual antiplatelet therapy, with a DES or a BMS, doesn't matter what you use, bare metal or drug-eluting, they should get at least 12 months. That's the default, okay, 12 months. But what happens if they bleed? What happens if they think they would benefit from extended duration of antiplatelet therapy? Well, the guidelines support that now in ACS patients. If you think your patient who was treated with a PCI now is having bleeding and is not getting benefit from antiplatelet therapy, if your patient is not having bleeding and you think they would benefit from getting extended duration, the guidelines are saying go ahead. But you have to be careful, make sure they don't have the risk factors for bleeding that we always talk about. So they're saying you can extend beyond 12 years. Now there's a trial out there that supports ACS largely with STEMI patients with extended duration Ticagrelor. That was the Pegasus trial, and that was a reduced dose of 60 milligrams twice a day. After you've completed 1 year of 90 milligrams BID. So that was with Ticagrelor. Now, what if your patient is having bleeding, or they're not tolerating dual antiplatelet therapy, or they have to go to surgery? Well, the guidelines now come in and say, it's not great evidence, but you can consider it, of shortening the duration to 6 months. Okay? This is with ACS patients. Like I said, this is very different now in stable ischemic heart disease, where the guidelines say we can do 6 months of DAPT. So very important to understand that. And then last, I'm going to finish up with what I talked about, the new kid on the block. It's not so much new anymore. This is the IV ADP receptor antagonist. This is Cangrelor. We have it on formulary here. Most of your hospitals probably do too. This was really a niche drug that it's an IV antiplatelet medication and has an incredibly short half-life. You're talking seconds to minutes. So you can see here the plasma concentration in green, and then we shut the drug off. Boom, the plasma concentration drops within 20 minutes to 0. And then look what happens to platelet reactivity. So platelet reactivity in blue is 0. The platelets are not clumping. The minute we shut it off, the platelets start reacting and start clumping. So this is a really powerful drug. You can think about where you would use this. And the niche in this is using this in perioperative patients that have had a recent drug-eluting stents within 6 months. You don't feel comfortable interrupting antiplatelet therapy. You stop the antiplatelet therapy a couple days out. You put them on Cangrelor. You go Cangrelor the day of the surgery, you stop it about 2 hours before they go to surgery, and they come out and you restart the dual antiplatelet therapy. It's a fantastic drug. The other way we're using this, which is a little bit off-label, is we're using this more in patients with MIs, with ACS. As you know, patients with STEMI and non-STEMI, or more STEMI patients, their antiplatelet or the antiplatelet agents have less of an effect for many reasons. Number one, they're in a prothrombotic state. But number two, a lot of these patients are in heart failure. They have edema. They don't uptake the oral medication as well. As many of you know, when you're putting antiplatelets in patients on a STEMI table, a lot of them vomit. They vagal and they throw the medication up. The last thing you want to see when you're doing a PCI and a STEMI, or 2 platelet or antiplatelet medications get thrown up in a tray. So with the advent of Cangrelor, it's not an issue. We just start an IV infusion and continue it after until the patient can take PO. So it's a really, really nice drug. And that's it.